Good evening, friends, and a warm welcome to the 39th episode of 4D. 4D stands for Detailed Discussion and Dialogue in Indian Diabetes. And through discussion, through dialogue, we hope to make a difference. We hope to make ourselves not just the diabetes capital, but the diabetes care capital, the diabetes control capital of the world. In this episode, we have with us one of the senior most endocrinologists of the country, someone who I look up to as a teacher, someone who has actually been able to walk the talk. Somebody who has got tertiary quality education, tertiary level. He's a DM in endocrinology, but who has gone back happily to his home state to practice at primary level. Warm welcome to Dr. Biplav Bandyopadhyay, who is a consultant endocrinologist at the Dhanvantri Hospital in Raipur, Chhattisgarh. Warm welcome, sir.
Thank you. Thank you, Dr. Sanjay.
Like we speak of 4D, there are four dimensions to Dr. Biplav's personality as well. He is an endocrinologist, he's a doctor that we all know, but he's also trained in law. Dr. Bandyopadhyay, thank you, sir, for having bridged this gap. He is also
Thank you.
he is also a very good orator that you will realize when you listen to him. But most of all, he is an advocate for person-centered health, and I think he is an advocate for simplicity in healthcare. So, if there is one thing that I've learned from Dr. Bandyopadhyay over the last 2.5 decades, that is how to make healthcare simple, how not to complicate it, how to make sure that we are able to translate it at the primary level. So, sir, our topic for today is challenges in primary care for diabetes and hypertension. But I'm sure you'll be speaking not only about challenges, but about solutions as well. So, warm welcome, sir, once again. And the entire country is looking forward to listening to you, learning from you.
Thank you. Thank you, Dr. Sanjay. Challenges in the primary care for diabetes and hypertension. Dear friends, we will discuss today that what are the challenges we are facing in the primary care. Primary care means first time when the patient goes to the clinic or hospital. It may be government setup or private setup. When the first physician, healthcare practitioner sees the patient, then what are the challenges are faced by him or her. Next slide, please. So, diabetes in India is advancing very fast, and in India, 1 in every 11 adults are diabetic patient. One half of the adults living in India with diabetes are undiagnosed. Number of people with diabetes in India are second largest in the world after China. Since we are crossing the population of China, the number of diabetes patients in India will be greater than China by year 2025 or so. 4 crores adults in India have got impaired glucose tolerance. So we are having about 9 crore adults living with diabetes, and we are having about 4 crores adults with impaired glucose tolerance. The rise in number of people with type 2 diabetes is driven by a complex interplay of socioeconomic, demographic, environmental, and genetic factors. And most important thing is diabetes gives rise to complications, macrovascular complications of the bigger vessels and microvascular complications of the smaller vessels. So 747,000 death occurs due to diabetes every year. Next slide. So in this complicated situation of diabetes, the hypertension adds to the misery of the people. And there are about 29% adult population are hypertensive. There are about 214 million hypertensive people in India. Whereas the diabetes in 90 million, hypertension is much more in number. And that leads to complications of hypertension, that heart attack, brain attack or stroke, and kidney failure are the three most common complications. 33% of adult Indians living in urban area are hypertensive. 25% of the rural population are hypertensive. If you see the male female ratio, 21% Indian men are hypertensive and 22% Indian women are hypertensive. And hypertension leads to, as I said, coronary heart disease, that is blockade of the blood supply to the heart muscles, leads to kidney problems and leads to the vision loss. So, causative factors of hypertension and its complications are age, alcohol intake, obesity, stress, disturbed lifestyle, increased salt intake, inactivity, that means sedentary lifestyle, bad diet, high cholesterol, high fat, the diet which is supplied by the most of the junk foods are increasing in India. High BMI, that means weight to height ratio, and tobacco consumption, smoking, and also different form of tobacco which are consumed in various part of the India. These all complicate the hypertension, giving rise to the mortality increase in the urban as well as in rural population. Next, please. Challenges in primary care diabetes and hypertension are many because if you don't face the challenges, you cannot control the hypertension and diabetes, and poor adherence to the population to the drugs which they should take, lifestyle they should maintain, and try to avoid the complications. So, a lack of general awareness about diabetes, hypertension, and its complication is rampant. So, this is the duty of the primary care physician that awareness about diabetes, hypertension, and complications should be spread in the clinic and also outside the clinic, going to the population. Diagnosis and access to the treatment for diabetes and hypertension should be available in all remote areas. It is not that the diabetes incidence is less in villages than in urban areas. Hypertension is also rampant in rural areas. Maybe we are not able to pick it up. So, the diagnosis and access to the treatment should be available, and economic disparity between urban and rural setting. It is fact and truth that per capita income in urban and rural setting has got vast difference. So this economic disparity has to be met with. Those who cannot afford medicines and healthcare due to not having money in their pocket, the government should come and support those population via those who are poor. Scarcity of the qualified healthcare personnel is present till today. Of course, many doctors are being produced by government and private institutes. Still, qualified healthcare personnel are deficient in most of the areas. Then the financial constraints, the expenditure by the government in the budget is only 2.1% of the GDP. So that should be raised to minimum 6%, which is there in most of the developed countries and also some developing countries. So 6% of the budget should be spent for health. Then there are social barriers, the customs, beliefs, those has to be broken with scientific knowledge. That way, we can control and make the people adhere to the prescribed medicine by the physician and regular follow-up can be maintained. Next slide. So there is also a factor that lack of evidence-based decision making is not there. So there are no uniform policies which should be applied in the primary care setup for diabetes and hypertension. There are no rule of laws. A study showed that in the public sector, that is government sector, there seems to be a greater need for strengthening the capacity to follow the available guidelines. So there should be an approach, there should be defined approach how to go ahead with the patient of hypertension or diabetes. Whereas in the private sector, communicating uniform guidelines are not there. So when you communicate with the patients, if the guidelines are uniform, then it will encourage the use to support the decision making at the primary level, at the secondary level, and in the tertiary level. Next slide. So other challenges to the primary care for the management of hypertension and diabetes are lack of communication. The primary health centers are so overcrowded that the professional doctor has no time to communicate about the primary health care of the population, or they are not willing to do it because of the lot of reasons. Lack of resources such as steady supply of the medications are not there. In government supply, sometimes medications are available, sometimes not available, sometimes available. If we need the telmisartan or losartan, the other antihypertensive will be lisinopril or enalapril will be available. Sometimes amlodipine, the amlodipine is available, sometimes other. So laboratory supplies and medications take a lot of time to procure them, and there is no smooth supply of the medications and laboratory reagents to diagnose the problem properly. The information system is quite inadequate. Of course, these days, government is trying to do propaganda about their activities and their achievements, but they are less scientific than a social propaganda. So inadequate information system exists in follow-up and revisits of the patients. In private sector also, patients follow-up and revisits are very irregular. That is also patients' responsibility to be regular with their management so that the diabetes and hypertension can be controlled, because more than 50% of the diabetes is not controlled properly. Hypertension is also not controlled properly. Poor support for the self-management. If the person wants to do self-management, then they require a lot of knowledge, lot of support of family, friends, society. The doctor-centered care process that impede adequate counseling. So everything, whatever advice is being given by, is by the doctor. We don't have many healthcare professionals which are associated with the management of diabetes, like nurse educator or counselor. They are not there in our system. So everything is done by doctor, and doctor cannot give lot of time because of the paucity of the time and resources to all the patients. So approach should be multiple healthcare professional, nurse educator, counselor. These they should be recruited in the system so that better care can be given. Next slide. So, strategies for diabetes patients and hypertension will be being physically active for the patient. The patient should be advised to do regular physical activity that can lower the blood pressure and help manage the blood glucose levels, besides providing other healthcare benefits. Current Central of Disease Study Disease Center guideline of USA recommend the minimum of 150 minutes of moderate intensity aerobic exercise each week or 75 minutes of vigorous intensity exercise each week. There are multiple guidelines. Some people say the 75 minutes exercise in a week should be sufficient. It may not be moderate or may not be severe. It should be some stretching exercises, muscle strengthening exercises should be included in that. One should maintain a healthy weight. The BMI should be calculated. The weight to height ratio. The people with excess weight should lose at least 5% of their body weight. That can reduce the risk of high blood pressure and diabetes. National Heart, Lung and Blood Institute of USA noted that 3 to 5% loss of blood weight can improve blood pressure significantly. Next slide. So, a healthy diet is always advised. Traditionally, our Indian diet had all the substances that are required to make it healthy. It had all fiber, it included fresh fruits and vegetables, at least 5 parts. The high fiber food was there in our traditional diet, like whole grains, as well as millets. This year is the National Millets Year. So the millets which are available more in the village areas, and the millets are traditional food for the Adivasis. So India is celebrating Millets Year, and that is being propagated to make the people aware that added salt and free sugar should be avoided, and carbohydrate in the form of complex carbohydrate should be taken. The unhealthy fats like trans fats and animal fats should be restricted, and healthy fats like ghee, polyunsaturated fatty acids, and some saturated fatty acids in low amount can be taken. One of the most important part is quitting tobacco consumption. Tobacco consumption, and in other areas tobacco is consumed as oral chewing tobacco or nasal tobacco, or it may be in the form of manjan, which you call as gulaku in Odisha, Chhattisgarh and adjacent part. That is mainly gur and tobacco, resulting in temporary increase in the blood pressure, causes increase in the plaque formation, which can lead to increase in the blood pressure over time. Tobacco smoking can also increase the risk of type 2 diabetes. Tobacco with diabetes and hypertension have a triple risk of developing serious complications, including heart and kidney disease, retinopathies, which can lead to blindness, poor blood flow of the limbs, making infection prone, and risk of diabetic foot and amputation are more likely. Peripheral neuropathy, that means loss of sensation in the big nerves, legs and arms, can also lead to the complications. Next slide. So, treatment strategies of diabetic patients has changed in recent years. Previously, we were using stepwise approach, gradually increasing one after one medicine and seeing the control. But the research has shown that legacy effect, that means the controlled blood sugar in initial years of the life of a person, has got great impact on the complications of diabetes later in their life. It may be up to 9 years or 10 years. So, early initiation of combination therapy, we should try to control the blood glucose as quicker as possible, but not very quicker. We should not bring down the HbA1c from 10 to 7 within 1.5 months or so. We can control it over a period of 3 or 4 months, and we should use the combination therapy for achieving glycemic goals and delay the deterioration of the glycemic control with better preservation of the beta cell function. So novel medication therapies are used with diet and exercise to control high blood sugar in adults with type 2 diabetes are DPP4 inhibitors, the sitagliptin, saxa, linagliptin, alogliptin. SGLT2 inhibitors are there, like dapagliflozin, empagliflozin, and canagliflozin. GLP-1 receptor agonists are there, but they are a little costlier and difficult to use because of their side effects. So, when the kidney is the main functional area of SGLT2 inhibitor, this is basically called as incretin substance. It causes glycosuria and thereby reduce the glucotoxicity. In pancreas, it has got indirect effect with incretin effect, causes increased beta cell sensitivity and decreases the glucagon. DPP4 inhibitors are basically incretin drugs, and they also have got action over the pancreas and intestine, thereby secreting more GLP-1 and GIP. That causes the combination causes the weight reduction, reduction in the systolic blood pressure, hyperglycemia, reduction, the pleiotropic effect of the drugs are there, and weight neutrality of the DPP4 inhibitors and weight reducing capacity of the SGLT2 inhibitor can be added together to make a fixed dose combination of SGLT2 inhibitor and DPP4 inhibitor, and that can be a suitable option for Indian type 2 diabetes mellitus patient for the reasons that they are safe, rapid, and causes sustained glycemic control. They improve both insulin resistance and beta cell function. They help in reducing body weight and blood pressure. They are extra glycemic effects. Reduces the pill burden, number of the pills taken by the patient per day, and adherence and to the compliance. And overall, these are cost effective. So this way, we can say that the combination therapy in management of type 2 diabetes mellitus, also the combination therapy of in hypertension, the research has shown that other different groups of drugs in a lower doses and a combination therapy is useful in hypertensive patients also, and they can be better controlled.
Thank you, Dr. Biplav. A wonderful presentation. And the beauty, I think, that Dr. Bandyopadhyay has brought to this discussion is uh, tertiary level education, tertiary level evidence being put into practice at primary care level. I think that is the beauty. Sir, how challenging has it been for you to translate whatever evidence you learned in college, whatever evidence you learned from latest guidelines, from latest research, to translate that into practice? Is it difficult to communicate to your patients? Is it difficult to motivate them, or is it an integral part of your life now and you've become good at it?
Well, it is difficult. It is difficult because what science we are trying to make the patient understand, sometimes they are not able to follow it because they are coming with such a background where there are a lot of misinformation which patients are carrying, and those misinformation causes the patient to accept our advice. Second thing, most important, is the follow-up of the patient is not regular because of the financial reasons, because of the reasons that they cannot reach the hospital in time. So these factors are there. So whatever we are trying to teach the patient, what we want to advocate and we want to make them learn, they are not able to follow. But I have seen that the rate of not following is not different in the rural and the urban population. Urban patients are equally negligent. They
Hmm.
won't come when you are given 2 months interval for their follow up. You ask them multiple times to maintain yourself SMVG, self monitoring of the blood glucose levels. They will not do it. And then they will come after 2 months or 3 months with a raised blood glucose level. So, compliance is a problem with both rural and urban population. Sometimes rural people are better. Whatever you
Yes,
have said, they believe it
and they
and
follow.
they know they follow it. So, our problem is to disseminate the information through the various sources. Alone, we really cannot do much as a physician.
So, health
Sadly,
literacy is not necessarily the same as literacy or financial
true,
status.
true, true,
Sir,
true.
one question we have, like you've talked of urban and rural, if there is a difference, the rural population is more adherent to our therapy. One question coming from the audience is, there is a high rate of malnutrition across the country, and we still have a lot of adult malnutrition.
Right.
Still, why are diabetes and hypertension so prevalent in our nation?
So I think that in our area, where the adjacent Odisha and Andhra and Chhattisgarh, malnutrition is really a problem. And whether the initial the Katak, Dr. B.B. Tripathi and all that suggested that protein deficient malnutrition causes diabetes, that evidence is not found today, because that type of pancreatitis we are calling it as secondary diabetes due to pancreatitis. So malnutrition is there because basically carbohydrate eating population, and they take less pulses, less protein. But lean type 2 diabetes, which convert into insulin dependent diabetes, are much prevalent in the village populations. So it is basically one some autoimmune phenomena which is prevalent in rural as well as urban population. Urban people are more obese and therefore diabetic, and they are having immunological factors like autoimmune disease, so they are diabetic.
Sir, you've spoken of drugs and you've also spoken of lifestyle. And I was really impressed the emphasis you have placed on lifestyle modification. Now, a question is, when a person comes with diabetes, the person is already prepared that the doctor will tell me to reduce carbohydrate intake, sugar intake, and ghee intake. But for hypertension, uh, let us ask multiple questions together. One is from the doctor's point of view. Do you think we put adequate emphasis on salt restriction? That's one question. Second is from
Actually,
the patient's point of view. Do they accept it the same way they will accept carbohydrate restriction in diabetes?
Actually, the science is not very clear about the salt restriction. So some people are responding to salt, some people will not respond to salt, and we don't have any clear-cut demarcation or some method to investigate that who will respond to salt and who will not respond to salt. But in practice, you can ask them patient to take low salt. But what is low salt? That is not clearly defined. Low salt is less than 2 gram, or low salt is less than 5 gram, or it is less than 10 gram or so, maybe in some people. So it is not very much defined. So we are also not specifically saying that you should take 5 gram or less salt. Ideally, it should be less than 2 gram. So that is the problem. And then we are having a combination therapy where we are giving a lot of diuretics also. So many of our patients are having hyponatremia with hypertension.
Hmm.
Many patients in our tertiary practice, we see many patients with hypertension with hyponatremia. So there we have to ask the patient to take salt. So about salt, probably black population respond better to the salt restriction, and whether we Indians are between black and white, and what is our genetic characteristic, probably it is not clear.
Sir, what is the salt intake like in eastern India, in Odisha, Chhattisgarh, Jharkhand? We are just curious to know. The
Yes, it is
local
lost.
cuisine, is it high in salt or it's okay?
Yeah, I think they are taking between 5 to 10 gram salts minimum. It is on higher side. So basically, when you take rice, you have to take a lot of salt. if you're taking chapatis, you need not have much salt. But for rice, more salt is taken,
required.
especially in the traditional diets.
When we actually see data from across the India, we see that salt intake is highest in the northeastern states, including Sikkim, and that is where the incidence of stroke is also the highest. So that is from observational studies, from epidemiological studies.
Right,
From
right,
all India perspective, a few things we do tell our patients. We talk about something called Pareto's law. Now, this was from economics, where Pareto said, he was an Italian economist. He said that 80% of all the wealth of a country is owned by 20% of the people. So 80% of all the salt is actually contributed by 20% of our food. So the dangerous K's will be Karela, Kathal, Kadi, Kurkure. High salt
right,
taking,
right.
salt sort of attracting vegetables.
Okay,
And the dangerous P's will be pakoda, papad, pickle, pizza. So these are the dangerous P's. So we tell our patients to avoid them. Sir, a few
right,
more
right.
questions if you allow. You've talked of awareness, we've talked of diet, and now coming to drugs, you spoke of diuretics and the need to monitor sodium as well, especially in geriatric patients, in elderly patients. If
Right.
somebody comes in with confusion, it might be low glucose, it also might be low sodium. The question coming is that now we have new drugs which are used to manage glucose, which are also helping in reducing blood pressure, and which help improve long term outcomes. Do you see an impact on the use of insulin with these newer drugs?
Yes, there is there. Probably since 2015, use of insulin has reduced after the introduction of the SGLT2 inhibitors. So we are using, and therefore the C peptide level estimation has become little important, because C-peptide level will tell us that whether the patient is type 1 or type 2 diabetes, or whether it is going to be a type insulin dependent diabetes. But I have some doubts also, because we see many patients don't respond to insulin also. They are taking SGLT2 inhibitors also, they are taking DPP4 inhibitors, sulfonylurea, all they are taking if their pancreas is functioning, but still their body weight is not reducing and the blood glucose is not being controlled. So I have many patients like this, where we are confused where GLP-1 receptor agonist, SGLT2 inhibitor agonist giving together will work or not. So these are the different situations. You can throw some light on that also.
So I guess all drugs will be required because diabetes is multifactorial, hypertension is multifactorial, and there are multiple mechanisms leading to that. In hypertension, apart from the diabetes part, there is also a chance of fluid overload or salt overload. Then there is sympathetic overactivity, and that is why we have definitions for resistant and refractory hypertension. Similarly, we have refractory and resistant hyperglycemia as well, which doesn't
As well.
respond to multiple
Right,
drugs.
right, right. So maybe
Sir,
the bariatric surgery is the answer for them who
yeah.
don't respond to.
Or newer drugs perhaps, which are in development, and the drugs quality also keeps on increasing. But Dr. Viplav sir, one question again from audience is that the drugs are improving in quality. We have more and more drugs now, and you said that SGLT2 inhibitors may be able to reduce the need for insulin in some patients, in not all. Will lifestyle modification always be necessary for diabetes and hypertension, or do you
It
think
is
a
true.
time will come when people can do whatever they want and still enjoy a good life?
No, no, I don't think this is a very interesting question. That lifestyle modification will be always there, and if we don't, the nature has given us the heartbeats, the exercising capacity, everything is given by nature. And if you keep sedentary and don't do exercise, don't reduce your weight, you are supposed to carry a weight of 60 kg, and when you carry a weight of 90 kg, this will damage all the organs, starting from the muscle, bones, your heart, your kidney, your brain. Everything is affected by it. So lifestyle modification will be a center of the therapy of hypertension and diabetes. Probably in our clinics, we are not able to focus it much. We are not able to give them directly access to the physiotherapist or exercise therapist, but that is remains very much important. So,
Point well taken, sir. What sir is teaching us is that even if you are able to manage the metabolic numbers, supposing you go into hyperdrive and you give lots of medications, high doses, you may be able to correct the blood pressure number, the cholesterol number, the glucose number. But apart from the metabolic aspect, there will always be a mechanical aspect, musculoskeletal, mood aspect. Even if you take care of those with medicines, then mitogenic aspect or malignancy aspect of obesity. So all these complications will come up, and the best way to prevent them is to follow a healthy lifestyle.
true.
With this, sir, we are mindful that sitting is known as the new smoking, because if you keep on sitting for more than 20 minutes, the CV risk is equivalent to smoking one cigarette. So with this, I'd like to thank everybody who has logged in today for 4D. Today was our 39th session. And in 4D, you must have seen detailed discussion and dialogue in diabetes, in Indian diabetes. We keep on speaking about various aspects of the syndrome. And today, Dr. Viplab Bandyopadhyay has talked to us about hypertension and diabetes in primary care, which means that we can all practice this care. Whatever Sir has taught us, all of this can be achieved. We can translate it into practice in our OPDs. All we have to do is to use the same language, the right language, and we have to do it together. With this, sir, thank you very much for being with us. And to
Thank you,
everyone
Dr.
who has
Vinod.
logged, Jai Hind, sir.